to this workshop, online mental health awareness workshop, which is being organized as a part of World Mental Health Day initiatives that were initiated a few weeks back, with an intent to prioritize mental health in the workspace. As they say, a healthy workplace needs a healthy mind. So that's why the mental health issues have become very, very important these days. We are spending a lot of time, almost 8, 9 hours at a workplace, and the individual gets impacted by the environment and the workplace, as well as the environment and the workplace gets impacted by the individual's mental health. So that's why this is a very, very important topic, and it has become more pertinent in the recent times when what we are seeing is that there is a lot of pressure from social media, as well as sometimes we have expectations from our own self, which sometimes we are not able to meet up. So that's where I think there is a role for everyone in our workplace to help us maintain that work-life balance and maintain our mental health, so that we are in a way we are able to deliver what we are supposed to do in different spheres of our life. Work is, after all, only one part of our life. Work is not life, but many a times we tend to forget it, and that's why I think we need that balance, and we need that awareness that needs to be there with us. So I'm grateful to my colleague, Dr. Ravleen, who has taken the pain of organizing this workshop, and she has also put together a list of eminent speakers who will be talking to us today. We are grateful to DG ICMR, Dr. Bahal, for sparing time to be with us today. And sir, I request you to please give your opening remarks.
Thank you. I don't have much to say. I am not an expert at mental health in the workplace. Neither am I expert at work-life balance, because I think work and life are not separate as well. Life is bigger. Work is a part of life. It should fit within life. It is not that one side we have work and one side we have life. Actually, it's an important part of us. And it can give a lot of satisfaction, a lot of sense of accomplishment, well-being, if we are able to do our work well. So I'm not really an expert, but I know 3 things that I want to still tell you. The first is that all of us, we are living in a world where there is certainly the pace of life is much faster than what it used to be. And you should take time for calming your mind and doing something which gives you some pleasure, at the same time gives you something that you are not stressed all the time. And it's not just work, it's many other things that cause that. And physical activity, simple things like physical activity, yoga, meditation, allowing yourself to be calm, and all those promotional things that we can do are extremely important as far as I am concerned. The second thing I want to say is that if you think you have a problem, please don't think that mental health problems are any different from physical health problems. If you have a fracture or if you have pneumonia, what do? You get care. You get the best quality care. You get the best quality treatment. And similarly, if you have a mental health problem, my request will be, please seek treatment. Please seek care. And do not think that it is going to be any different, any other. The third thing is, empathy and understanding. We are people who all work on health. At least we should understand the issues related to mental health. If somebody else is having a mental health problem, don't try to make it into something which is, why is this happening? So all sorts of things that people do in, let's say, in the community. We need to learn how to at least have that kind of awareness that you are empathetic to those people who have any. So these three are my only request, and I leave it to the experts to tell us about the issues that they want to talk about, important issues. Thank you. Looking forward to, I will stay for a few minutes to listen to the first talk, then I'll have to leave. I have to stay. Thank you.
Thank you, sir. I now request Dr. Ravli to introduce Dr. Sagar.
So, good morning, everybody. It is my pleasure to introduce Dr. Rajesh Sagar, Professor of Psychiatry at All India Institute of Medical Sciences. He's been a faculty for past 28 years. And additionally, he's in a position of member, Central Mental Health Authority of Government of India for past 20 years.
They won't function.
We
can start with the presentations that we have already. Are some slides pre-loaded here?
No.
Just.
चेक कर लोगे तो एक हफ्ते में कर लेंगे सब चीज चेक कर लो भी टेस्ट कर रहे हैं अगर कोई पूछेगा तो कोई बना सकता है कि नहीं कुछ तो लगाया
Mute करो.
Thank you so much, Dr. Behel, ICMR, Dr. Kamini, Ravli, Sumit, and whole team. It's always a pleasure to come here and talk and discuss. And also, thank you so much. I can see many people joined online, and my co-panelist, Dr. Anant, Bhan, I can see Dr. Vijayakumar also. And what we know that we are celebrating World Mental Health Day in the same continuation, and what the theme this year, it's time to prioritize mental health at workplace. and which is so important and apt. And always I feel that why we should celebrate only on day one only or a week. I think mental health is important, that we should be discussing all through the year. But there are so many activities just concentrated on this. And just to tell you briefly, those who are not psychiatrists or mental health professionals, since 1992, the theme is given by World Federation of Mental Health. And every year the theme is given basically to create awareness, and because we know that mental health suffers with a lot of stigma and many issues. So that's the reason that and this is something positive I have seen over the years, that a lot of awareness has come by. I think what it used to be about 30 years ago, and now I think there's a whole lot of a difference. I think now people want to talk, we want to discuss, and that's something positive. And I'm very grateful that ICMR also has taken the lead with regard to mental health. I'm so thankful that many, so much support is there with regard to mental health. And in the recent time, that has increased tremendously. It's not just because mental health was important even before the COVID, but after COVID, it has really, it has come to the limelight that all over the world, including WHO, who have mentioned this point. So I thought that I'm aware that many medical colleges have joined. So to just make a formal presentation so that to put you in the context about the mental health and some of the important issues, what is happening in the world over, and also what WHO says. So that will give some clue to the what workplace mental health is. And also in the end, I have mentioned a few points about, because hospital is very important workplace. So at the end, I will, because since many of you are in the medical college, so some of the importance I will try to give of what is there in the medical college or hospital, why this is important, and some of the important clue can be taken from this, and wherever you are, and you can, we can discuss that later also. And so again, I said it's not one day thing, and I am sure our support is there with regard to mental health subsequently also. Next, please. Yeah. Okay, so this is the theme. Just to put the context, it's time to prioritize mental health in the workplace. That's a theme, and which is being celebrated all over the world. Next, please. Now, just to put the context, what mental health is, I think everyone knows, but here I have a purpose next to say that, because in the definition of mental health, again, we know it's not just the absence of mental disorder. Next. Then it's a state of well-being, we know. And then there are 4 points which are important, like realizing his or her own potential, can cope with the normal stresses of day-to-day life, like stresses are important part of mental health. Next. Then can work productively and fruitfully. That's the reason that I have put this up, to say that mental health and work go hand in hand. And it's what the definition WHO has given. And one of the 4 components is with regard to work productively and fruitfully. And also one who can contribute to the society and the nation. I think that's again an important component of mental health. So these are the 4 components, including the work productively and fruitfully, which again is a theme of this year World Mental Health Day. Next, please. Then again, to just shift a bit, like because that was mental health, and what mental illness is, again, it's important is that it is a health issue. I'm highlighting this because many times we think that people go to faith healer, people go to traditional healer, they think that mental health is not a health issue. So we want to put in the context that it's an important health issue, where how the person feel, think, behaves, or interacts. But again, you can see the important thing is that it is not only the symptom as such, because many times we just say casually, this person is depressed, I am anxious, but that does not mean that he has or she has a clinical depression or depression as a disorder. So to say that it's a disorder which requires help, there are two things which are important, that one has to have a distress and a disability. And again, this is a very, very important thing. Disability means that how a person ability to function as such across different areas, including the relationship and also maintaining work and so on. And so again, here we see that mental illness in the definition itself, the work productively and the functioning is important part of when we make a diagnosis of any mental illness. Now, to start with the positive thing, I think I will just say that work also has a beneficial effect. I think we'll start with positive aspect, and whenever a person come to us in the clinic, we always say, why don't you go to work? We want to mainstream. So work has many benefits with regard to mental health also. Working is a very crucial thing. At this one point, it has a positive thing, and also that it can also create a stress also. So why? Because it gives a purpose to a person, and it also there are opportunities to meet people and make friends. We all know that at workplace where you have friends and so on, we interact, we discuss, and also it gives a sense of self-worth. We all know that, and also being valued by others. Because if a person who is working and you can imagine that sometimes person who is unemployed itself is a huge stress, even to the tune of even person who attempts suicide. They are the one who are unemployed and who are not working, or who have been out from the work and so on. So you can see that work has a beneficial effect on the mental health. Yes, please. Now, what are the issues with regard to workplace and mental health? I think the world across, I think one of the major concern has come is problems related to anxiety and depression, what we call as a common mental disorders. Now, the numbers are staggering. You can, next please. Then, because it does have an economic impact also, I will say that how it does have economic impact. And up to 30% of those who are working will experience some kind of mental health problem during their working life. Again, this is all over the world. Some of the important data is some say 15%, and there are also figures of 30% and so on. Next, please. Then causing worry, sleep problem, fatigue, and so on, which again are related to work. Next, please. Then affecting their ability to function at work. Then harassment and bullying. I think that is something very, very important and serious. And we know that many times people come to our clinic and they do talk about this, that I am being harassed, I am being bullied, my seniors are not taking me, they always shout at me and so on. So I think, and it does have an adverse impact on mental health, and to the tune that can be so stressful that even person doesn't want to go to work, or even at times may have a attempt of suicide and so on. Next, please. Now, these are some of the staggering figures, which again are not mine. These are all WHO global figure. 1 in 6 people will experience mental health problem workplace. I think you can see the number. 17 million work days are lost annually worldwide due to work-related stress, depression, or anxiety. You can see that how such a huge number. Up to 80% of people are affected by work-related stress. These are all what globally this, and the most important is the loss of $1 trillion per year, lost productivity due to employees' mental health problems. So you can see the number. It does have as I said earlier, it has a economic aspect to any nation, and to the tune of $1 trillion. Next, please. Now, again, you can see the numbers here, that 60% of people, they do work. So we all know that 60% people are working, and many of them are informal economy. I think, in fact, just last week, the Ministry of Health, where I was one of the speaker for a session on informal, those who are in informal sector. We are aware that formal sector, lot of efforts are there, but people who are in formal sector, they are huge number. 80% of the people are in formal sector. Informal means like daily wage workers and domestic help, and so that's a huge number, and no one takes care of their health. In fact, I was surprised to know that even ESI does not take care of their health. So that's one of the important group, which is a huge number, often neglected with regard to health issue overall, including mental health. And the huge number of people are unemployed. Again, And you can see that the prevalence of anxiety almost 300 million. You can see the number of depression also same, people died by suicide. Again, these are global figure. And you can see that 50% of the impact is huge to the society with regard to mental health, and also 12 billion overall are lost every year as such on depression and anxiety. Next, please. Now, this is a very, very important study which I just want to highlight. This again is a meta-analysis by Harvard Business School where 228 studies of meta-analysis was done, and these are some of the 10 important workplace stress with regard to mental health, person's overall health. And you can see the numbers that stressors increase the nation's healthcare cost by 5 to 8%. Job insecurity, again, so important. It increased the odds of reporting poor health by 50%. And long working hours, I think that's a concern now, even for the doctors, where the mortality is increased by 20%. And this is the meta-analysis of 200. Thank you. So you can see all these are the factors like shifting the work, long hours, job insecurity, work family conflict, and so on, high job demands. So these are some of this, the meta-analysis and some of the findings. And you can see some of the important point, and the most staggering is the mortality increased by almost 20%. Next, please. Now, again, these are some of the important, in our own country, you can see that the figures are huge, the magnitude is huge, up to 50% people experience depression, 57% up to anxiety and stress, almost 75%. Impact is also huge with almost near half of the employees, and common symptoms, again, depression, burnout. Burnout is, nowadays we talk so much about burnout, irritability, sleep problems, anxiety and so on. Sleep is also one of the important thing where whenever one presents sleep, it starts with a sleep problem which a person notice or family member notice, and lack of support. Now again, this is very important what is being found, that only up to 25% of workers feel their workplace is supportive. So that means 75% felt that the workplace was not supportive at all, and only 10% had the employees assistance program. Like in the formal setting, this is also important thing. Many corporate international group, they do have something like an employees assistance program, which is there. Again, that's an important thing whenever we talk about workplace stress. Next, please. Now, these are some of the important things which has come up newspaper headings, like the important EY case which happened, the unfortunate death of an employee in Pune. And many such discussion had happened that the rising workplace stress, and that's this year theme is so apt, and I think we all as a health professional need to be aware of it and take a cognizance of this fact that many people are under stress, and that is why this type of discussion becomes very, very important and apt. Next, please. Okay, so now what are the factors? Just to give a glimpse, I will not go much into detail. Next, please. You can, yeah. So these are the important 5 factors you can see. One is the job design, then home work conflicts. We just heard about work-life balance and so on. Team factors, then organizational level factors, the individual factors. So all these are important whenever we have to think of any policy or any guidance or any guidelines. So we have to look into these factors. It may be related to the job. It may be the organizational level. Again, the people who are there. Sometimes people get so upset or distressed because the people around or the environment. We just heard about the role of environment. Environment plays a major role in your own mental health. So you can see a stigma overall. And so you can see that these are the important work-related factors which can induce a stress in a person. Next, please. Now, how to identify? I think simple. I'm not going to much details of that, but physical symptoms, problems with energy, sleep problems, appetite, physical symptoms, mood changes, rapid changes in mood, experiencing sadness, anxiety, and so on. Behavioral symptoms, restlessness, drowsiness, ways of thinking. So these are some of the important symptoms. So anyone can recognize, and who is undergoing stress, either in himself or herself, or to your colleagues or any family members. Next, please. Now, this is just to tell you the sources are multiple, work related, I said one, but there are also life issues also which are hidden, which we do not know. What we just see is the symptom, which is the tip of the iceberg, but many things are hidden, like health issues may be there, which again may lead to a lot of stress. Not only health issue in yourself, but also in a family member. You can see anyone who is working, how so much upset they are when their child is, having illness, or their parents are having illness. So all these are important, which are hidden. We do not know much about it, but whenever we have to talk about it, I think this becomes very, very important. Next, please. Now, these are again early warning signs which anyone can identify. Anyone who is, where in the organization where you are working, the employer can identify, the person himself or herself can identify, like unexplained absences, that sick leave, absenteeism is one very important thing. Many times this happens that anyone who is on unexplained sick leave, absenteeism, poor work performance, poor timekeeping, headache, frequent backache, tiredness, poor judgment, indecisiveness. I'm not able to, decide what to do. Irritability, anger, tension, conflict, withdrawn, not interacting with people. So these are some of the important warning signs. If it is there, you can identify that person is under stress and requires some kind of help. Next, please. Now, these are again consequences of mental health problem in the workplace. So, earlier we discussed the other way around. These are the consequences of mental health problem. Like because of mental health issue, there may be absenteeism. As what we discussed, work performance may be lowered because of that. That is why we have a economic loss, staff attitude and behavior, relationship at work. So all these have important consequences with regard to mental health issues and problem at the workplace. Next, please. Now, you may think that, what are the issues? Like sleep problem may cause low quality of work. You know yourself, whenever we do not have a good sleep in the day before, then how the mood is so bad, your quality goes down next day. Lack of concentration, what will happen? This will give rise to procrastination, more accidents on the job. Especially this is important to people who are in heavy machinery kind of work they are doing. So you can see that if the concentration is not there, so it can lead to some of the serious implications. Then slowed thought, troubled decision making, forgetfulness, again poor quality of work, self-medication also happens, which again presentism means that those who are in the office physically, but mentally they are not. They are not into the work, and many times we have seen this aches and pains, irritability, low motivation. Also, I think these are some of the negative mental health impact on the work overall one can identify. And these are the common mental health condition: adjustment disorder, anxiety, depression, burnout, substance use disorder also happens, insomnia, absenteeism, somatization, poor quality of life, worsening of pre-existing mental health or the physical health condition. Next, please. Now, burnout, again, this is nowadays we do talk a lot, it's the buzzword now. What actually it is just a state of emotional, mental and physical exhaustion. The term is exhaustion, those who are in the excessive and the prolonged stress over a period of time. What is the problem with the burnout? Because the motivation is lost, and also it can happen to people who are the caregivers of chronic illness. Like chronic illness means like a person, caregiver or person in the family who has dementia, or even schizophrenia or any chronic illness, or any health, or even in health professional also. We heard during the COVID time, many of the doctors had a caregiver, had a burnout and so on. Next, please. Now, we all think that stress has a link with a psychiatric disorder. Not so. Whenever you go to diabetes doctor or doctor with a cardiology, they will always say, reduce your stress, reduce your stress. So it has an implication to the overall body. All other symptoms can be manifested along with psychiatric symptoms, depression, anxiety, and so on. It has a link with a physical or medical condition as well. Next, please. Now, anxiety, just to tell you, it's very easy to make a diagnosis. It's a very common symptom, like being worried or fearful or making excuses, panic attacks. Again, these are very common, which are often ignored: restlessness, irritable, and so on. So by this, you can easily make a diagnosis of anxiety. Next, please. Depression, again, it's a very, very important condition. low mood, there could be irritable, low confidence, loss of interest in work, decreased sleep, and so on. So this is by if it is there for more than 2 weeks, so possibly the person is having a depression. And the top of it, earlier I said that you need to have disability and also the distress. So this has to be there. Next, please. Now, just management, I know I will go briefly because next speaker, Dr. Anant Bhan, will talk more in detail about it. So just quickly, I will go through. First and foremost, I think recognition and acceptance of mental health as a legitimate concern. I think that is the most important thing. One has to, because many times people are under denial, they don't accept it. I think that I feel is the most important thing. Next, please. Now, these are few things like stress first aid, that is what which is important. Is the way how we respond to the stress with regard to work stress or any stress, and so there are 5 goals as such, like safety, again, which is important for any place, even when we are working in the riskier place, where the safety is the foremost concern, the calming, how to reduce the anxiety, feeling connectedness, connecting with the family, and so on. Then sense of self and thank you, sense of hope. So all these are important. Next, please. Now these are different levels. I will not go into details. First level, stage 1, you can see making lifestyle choices. Our DG was talking about it, how we can change our lifestyles, yoga, meditation, exercise, and so on. Then stage 2 is dealing with the problem like team engagement, conflict resolution. Again, at the organization level, these are important. Then the stage 3 is changing the perspective overall, like taking care of depression, anxiety, and seeking a professional help. And that's what we heard, that seeking professional help also becomes very, very important. Next, please. Then again, these are integrated approach. The first is preventing harm, again at different levels, promoting the positive, which is there, the strengths which are there of your feeling of well-being, positive mental health, and positive organizational behavior. I think this will hold true for all organizations, scholarship, and so on. And responding to problems. Again, anyone who has a problem, one can talk to them, discuss with them, stigma reduction, accommodation. I think some people we know that require some accommodation. Many times we do that. Those who are under problem, I think that is what an organization needs to do. Next, please. Now, these are at different levels: prevention, promotion, and support. And these are some of the important interventions which can happen. And the most important, the bottom, you can see, create an enabling environment. I think that becomes a very, very important. And whenever we think in terms of making changes at the organization level, I think that is what the whole ultimate goal is, to create an enabling environment. Next, please. Now, these are some of the WHO has given guidelines, organization level intervention to improve the workplace mental health, promote mental health awareness. This is what we are doing today. Foster a supportive work environment. So any organization level one can do, offer access to mental health service, again, which is very, very important. Training of managers, work-life balance initiative, and so on. Next, please. Then stress management program, regular monitoring workplace. In fact, last year also I gave in ICMR a lecture on stress during the month of September. So again, many organizations do. We get a lot of calls many times where how to manage stress. In fact, recently National Academy of Medical Sciences also have been very, very proactive whenever they have a program. Even INSA is very, very active to in their leadership program. So much talk is there about taking care of mental health and the stress, inclusive policy development, recognition award, crisis intervention support, and so on. Next, please. Now, these are again some of the important points. I will skip this. Next. Now, intervention in India setting also, the ESI hospitals are there. There are certain NGOs who are working, legislation are there, prevention of sexual harassment, just giving a glimpse of all this. So anyone who is there in their own organization can look into it. Childcare services are important also in the any workplace, industrial organization, psychologists, and they also play active role. Grievance redressal, again, many organizations have adapted to reduce the stress of a person. I think they all are important to improve the morale of the people and improve the well-being of the employees. Next, please. Now, mental health professional has an important role. This is what we are discussing. Employee support with counseling, stress management, workshops, again, can be done. Many places are being done already. Resilience building, mental health education, supportive policy, crisis intervention, even consultation. I think that becomes important overall. I think, and this will be something for the future. Many more people, organizations will come forward for all this help and support with regard to mental health issue. Next, please. Now, just I will talk briefly of, because many of you are from medical college, so because this will be relevant mental health issue, because this is also a kind of workplace. So I have added these few points. Next, please. Briefly, doctors, nurses, medical students are a group of high risk group. I think we all need to know that. Suicide, depression, anxiety are important. Even substance use are important problems in the medical college and hospital setting. Next, please. And this is a very, very important study. Anyone can see it published in JAMA. Like you can see, it's again a meta-analysis of 195 studies of more than 1 lakh students, 1,20,000 students, 47 countries. And you can see 27% of medical students had experienced depression or depressive symptoms. You can see 1 in 10, almost 10% reported suicidal thought, which is such a huge number. You can see medical students are 5 times more likely than general population to have depression. You can see the numbers are staggering. And 13% increase was there in depressive symptoms when they started a course. During the beginning or toward the later end, they were at increased risk for depression. Next, please. Now, these are the important point, because I know that many of you have joined, from medical college. Would be important. These are the problem which students face. Challenging work environment, often require long working hours, high intensity work, demanding loads, competitive atmosphere, high rate of stress and burnout, chronic sleep deprivation, and so on. So you can see that these are the important points which were highlighted in this meta-analysis paper. Next, please. And you can see that these are the barriers. It's not only the problem, they have the huge problem, but the important thing is that to seek help, there are a lot of barriers. People do not come forward for the treatment. I think that's a major issue, because they do not want to seek help. And we all know sometimes even for psychiatrists, doctors are not a sort of good patient, because they self-medicate, they do not take care of their own health. So I think this is the important message I want to give, and this again was highlighted that there are perception of stigma, lack of confidentiality, and their concerns are. I think these are the reason that they don't seek help. Many times they go to different hospital. Embarrassment is there when they come to for the care and so on. Next, please. Now, these are some of the pandemic. We all know that almost all had suffered stress, anxiety, burnout, and so on. Exhaustion, and these all have been reported. Next, please. Now, this again was studied by ICMR. In fact, was published 2022, and basically you can see the ICMR scale was used for burnout in this, and this was done on 10 states, 13 sites and 10 states. Published in PLOS One, and again it was reported anxiety, depression, stress, and so on. So all these important, and the factors were workload, lack of resources, and society stigma. So this is, I want to highlight here, because this ICMR funded study. ICMR themselves have conducted this study all across the country. Next, please. Now, this is the study which we did in the trauma center, and you can see that 50% had burnout and secondary traumatic stress. Secondary traumatic stress, the people who come with the trauma, they themselves feel under stress, in that way. 54% reported anxiety, and this is our own institute, and I'm sure in other hospitals also this would be there. But the important thing is, and the conclusion, you can see workplace intervention for the promotion of psychological well-being among trauma professionals are recommended. So I think this is important aspect which will be there other hospital as well. Next, please. And this is what we wrote about 15 years ago, stress and suicide among medical students. Time to act. I think now so much concern is there. We keep hearing medical students. I think many of you are from medical college. I think this would be concerned. So you just to sensitize you as an administrator that you can do a lot to prevent this suicide at your own workplace. Next, please. So take home message it's important public health issue. Bi-directional relationship is there, and consequences are tremendous. And early identification is important. Timely intervention. The role of mental health health professional is very crucial. Several interventions are there, and of course, important mental health issues in the hospital and the health worker. I think we can't ignore and deny that. Next, thank you so much. I think. We wanted to rush it, so I know that subsequently we have other speakers. So I just thank you so much. If anyone has any question, I would be happy to answer.
Thank you, Dr. Sagar. Very eye-opening presentation in terms of what all can cause stress at workplace. We all know these things, but they are not discussed very openly. So, you time and again highlighted that we do not seek treatment for this. So, what do you think can actually make people more and more, reach out for treatment? Is it more focus on the prevention services? Is it, what is it that you think can help with that?
No, that's a very, very important point, and because the problem is not a problem. I think not taking treatment and denying, I think that's a real problem. And there are a number of factors, and we have to think from their perspective. Like, say, for example, in my issue, suppose any doctor who has a problem, obviously for confidentiality, for stigma, they would not like to visit. So I think we have to understand this fact. Stigma is tremendous because I will tell you the reason being, even in any organization, and we can take any organization, like if anyone is seeking help, what will happen? They will be bullied. They will be, given a label. Tum to psychiatric ho, pagal ho, kind of those words will be given. So what will happen? That will further complicate the whole problem. Because the important message here is not to the person who has a problem. Person is to society. That we have to be supportive to them. We have to do handholding to them. I think if we are able to give that confidence to that person, then they will come forward. Because they are not coming because of these reasons. Because they think that they will be ostracized, they will be given label, their CR report may be disturbed because of this. But we know that all these, many people are supportive. But the kind of language at times we use to such people, so that puts them off at times. And that's the reason they do not come forward. And that's a major block. I think, but also the positive thing is that over the year, that has changed now. But again, that change is very minimal. And what it used to be, let's say 20, 30 years ago, so much stigma was there around. But now, at least that has broken. But still, much more needs to be done. Still, it is huge. People internally, they do not want to seek help for these reasons also, only because they think that their career may be spoiled. What the seniors will think. Others may embarrass them. They may mock them also. So that's the reason, and you can see that it's a major problem, and the kind of language we use at times for them. So that's the reason that they are not. So what is important? That's what I said. Create an enabling environment, supportive environment. If you have problem, and provide those accommodation also. And that is what all the corporates are doing. I am aware of those who are at risk. That they can take leave anytime if they are under stress. And they can just write to their, so this is what is happening now. But again, it is in some of the private corporate organization, I am aware, but I think not so much in other places. I think that awareness is needed, that the promotion of mental health, because many people at time also, I have not talked about the myths. Myths are that those who have mental illness, they are not a good worker. They are weak people. They can get angry, which actually all are myths.
Yeah, but they can be sometimes perfectionists, which actually go down that path.
Absolutely, absolutely. So we have to, in a way, create awareness. I think such type of interactions are so important, where you can change, even if we can change about 10%, that will be a good number to start with.
Are there any questions in the chat box, or anyone wants to ask anything to Dr. Sagar right now? In this world where success is measured in numbers and quantity, how can people with mental health issues come out? Share about the condition. People may lose jobs. Yeah, that's what Dr. Sagar was talking about. And which employer will be willing to spend money? And I also think it is not just like when my son was young, school will not, I used to think, we put so much emphasis on the school. The school doesn't do everything for the child. It is the home also. So it is your social ties and your family structure and all those things. I think they play a very important role in having that kind of a holistic understanding of your own, where you stand, what kind of expectations you have of yourself. So I think putting everything in workplace will also not be fair, and the society and your family and other relationships, because every time we talk about longevity, we time and again the importance of social capital is actually brought out. Whether that is the social capital at the workplace or whether it is the social capital outside the workplace, I think that helps in creating a balance.
Simple rule is that 1/3 rule, I say, that 1/3 person sleep, 1/3 at the workplace or education,
And
and 1/3 with the
doing
family.
something else.
Yeah, but actually that 1/3 in the family also takes away for many things. You have to do here, you have to travel, you have to, so actually it's not 1/3 in with the family time. Or your own personal time, which has been taken away for your work also. Many times we take work at home also, and that is why we need to have that clear distinction, because of many are workaholic, they want to have, because it's easier said than done, I know. And I may preach that, you should not work at home, but I myself, my son tells you are saying this, but you are not. So I know it's very difficult to take completely out, I think. But the important thing is some awareness. I think that's point what you mentioned is very important. They may be thrown out of the job, but this is to create awareness to employer people that they are like us. They may have a problem. They may have a mild transient problem. They may come out strongly also later on. So I think these are important, and let's hope that everyone their mental health is taken care of. I think that is important. Yes.
I have a small practical question. Like at the workplace, we all have stress. So what small things we can do at the workplace to get rid of it? So
very good point. Basically, in one of the last year, I gave a lecture where some of the tips can be there, which anyone can do. The most important thing is that your own thinking, what we call as a cognitive reframing. Like say, for example, you have gone to a boss was angry with you, said something. Then what will happen? Then you get a negative thought. That is what we call as cognitive errors. मैं तो खराब हूँ. इसका मतलब मेरे में कुछ है ही नहीं. I am so worthless, useless. That's the thought will come to you, and these are cognitive distortions. Now you can change that. You can say, okay, this time you can talk yourself. Say that, okay, no, this time I was not up to it. I will try to improve. Next time, I will go and try to see that I have done best from my side. So maybe the boss will praise you. So that's a kind of positive thinking that is there. The other thing is immediately it happens, and we tell children also when they're giving exam, just take 3 deep breaths. And whenever so much anger is there, the problem comes when you react to it. You just hold on to that part. And of course, there are some physical activity. Nowadays, in many offices, there is a treadmill is there, physical activity, you can spend time. And the most important thing I feel is so important, that being connected to your friend. You can just talk briefly to your friend sometime, having a time off from your routine thing, and think about it. And for the management, there are 3 A's which are important. And any stress management, always I say 3 A's. One is the first is awareness, 2 is analyze, the 3rd is act. So being aware that yes, this was a problem, analyze it. Okay, what was there where I did wrong? What was there I did? So analyze it. And then once you have looked for the solution, then act on it. So 3 A's. So these are some of the tips one can do, which can be helpful. Sometimes yoga, meditation, all this also does help. Then the most important thing, always I say, as a mental health professional, and my lecture always I mention, you know best what works for you. Doctor can only give a menu to you. Okay, like, okay, do this, do this, do this, do this, maybe 10 things we may prescribe. But you know yourself, when was the last time I had under stress and what helped me? For some, reading a book may be important. For some, talking to a friend may be important. So you know yourself. So it should be person-centric rather than a doctor-centric. So suppose if anyone comes to me, always I ask, okay, पहले कब कोई परेशानी हुई थी, you had undergone crisis. So they will say, okay, yes, I had this problem. Then what helped you in that? They will say, मैंने ये किया था. Then why don't you do it again? So each individual is unique. So it cannot be blanket. No, किसी में कुछ काम करेगा तो किसी में कुछ काम करेगा. It's like that. But one thing is one has to think, this is a passing thought, like, this period which is so negative is also like a sine wave, hota hai, chala jata hai, so one has to be positive in that phase. I think, and there what the resilience comes, and that is what the aspect of resilience is.
Thank you, sir. Thank you so much. This was a very interesting discussion.
And we can facilitate or we do it in the.
Oh, sure, sure. I did. She has a thing for you.
Oh.
I did for you.
Thank you.
Sumit, can you take it?
Always a pleasure. Thank you. Thank you. Nicely.
So moving on to our next speaker, Dr. Beena Koshy. She is pediatrician by training and professor at the Department of Developmental Pediatrics at CMC Vellore. She is also having charge of Deputy Director at CMC Vellore. She is she has been awarded DBT Wellcome Trust India Alliance ICPH Fellowship and has academic interest in early childhood development and autism spectrum disorders. Ma'am is joining us online. We welcome you, ma'am, and
Yeah.
please share your thoughts. Yes, ma'am.
Yeah.
Ma'am.
Thank you so much, Dr. Ablimji, Dr. Rajibal, Secretary General ICMR, Dr. Kamini Waliaji, Head of Descriptive Research, and Dr. Revlin Kaur and other team members of Descriptive Research. Thank you for inviting me over. I think for the audience, it might be a little bit of a surprise. No, why should there be a pediatrician at all in this panel? But I heard a little bit of mention about it in the previous discussion as well. It is not just about workplace. Lot of these mental health concerns, resilience actually starts from early childhood, and I will try to summarize the evidence and what our experience in the next 20 minutes. So what will be my talk overview about is will be what is the significance at all of early childhood. We all had fantastic childhood, and what is going on actually during that time. We'll just briefly gloss over the psychoanalytic theories in early childhood. I will like to even highlight some of the recent Indian perspectives that have come in there. And we have been doing community research for the last 2 decades plus, and we will pull in some evidence from there and look at some concurrent international evidence and try to tie it up with workplace mental health and nurturing care framework and some thoughts on the way forward. Coming to the early childhood and human life, actually, if you look at the table, the figure on the right-hand side, that shows actually how the human brain develops. Most of us are familiar with the first 1,000 days and say that, that first 1,000 days, including the antenatal period and the first 2 years of life is actually when the maximum brain development happens, neurogenesis, synaptogenesis, networking, pruning, all these happen in the first 1,000 days. And we know that this affects later childhood cognition and abilities. Is it just that, or is it something more than that? Let's have a look. So WHO has recognized this very succinctly and has put out actually the nurturing care framework to support the first 1,000 days. And we will look into it a little later as well. Let's look at the major child development theories. There are many. I'll look at the 7 major ones. I know a lot of psychiatrists actually on board. You all may be very familiar with this. Why we were thought of looking at this is to understand childhood is not very simple. There are a lot of conflicts going on, there are a lot of learnings going on. Definitely, in addition to cognitive development, it affects actually our mental health development as well. I think most of us are familiar with the Freudian theory of psychosexual development, starting from the oral stage, anal stage, the phallic stage. We'll concentrate on the first 5 years of life. And to look at actually, there are the id, the superego, ego, which actually are a little bit hidden, which guides actually our thoughts, our actions, and our behavior externally. It's been postulated quite a while ago. Lot of criticism that we will come into that, but it's good to remember there are different stages actually from a psychosexual perspective. Erikson is actually one of my favorites, but remember, none of the theories is 100% perfect, but it talks about different struggles or challenges the child faces and how they do conflict resolution and come to have a virtue at the end of each stage. So if you look at the first 5 years of life, we talk about the infancy, trust versus mistrust, where they trust a caregiver. Early childhood is about how much autonomy they can have versus shame and doubt. And the preschool years till around 5, 6 is how much initiative can I do? And with that initiative, what all, makes me feel guilty as well. And we come to the Piaget's cognitive theory. Mind you, all these theories are very complex. I'm trying to simplify it for the today's talk. We know that from Piaget's approach, sensory motor is actually predominant. It just binds with actually Freud. Can you hear me?
Yeah, we can hear you. Please go ahead.
All right, okay. So it ties in with what Freud talks about the oral stage. A lot of learning happens sensory motor, and which moves on into the preschool years as a pre-operational and then moves on. Coming to learning, there has been a talk about Vygotsky's sociocultural theory, where if you look at Piaget, Erikson, and Freud, they all talk about individualistic learning or developmental patterns, while Vygotsky put a lot of thought into what's a culture, what's the language, and what the thought process is. And also the zone of ZPD we call zone of proximal development, which, excuse me, which we use in learning even in school years. So the sociocultural theory actually is a little bit more interactional, where a lot of scaffolding happens around the child, which helps them to develop and move forward. This is a famous Bowlby and Ainsworth attachment theory, where the interactions in early childhood results in either a secure attachment, where the child is quite secure in each relationships and the primary attachment phase itself. And there can be different other types of attachments as well. When you look at the stages, there can be a pre-attachment, which is early stage, then an indiscriminate attachment when they get attached with all caregivers, then a very discriminate attachment with the primary caregiver. And as the child grows up, they have a stage of multiple attachments, which actually evolves over time. I'm also a big fan of this Bronfenbrenner's ecological systems theory, where he suggests that it's not the individual that stands alone. There is a microsystem. And look at that, the workplace comes there. Before the workplace, it's a school system, the friends, family, neighbors. Actually, there's a microsystem, then there is a mesosystem, and there is a macro system and the exosystem. So different systems actually influence our behavior, our expectations. And this is actually a theory that ties up a lot of loose ends that previous theories couldn't explain. And we cannot overlook the Kohlberg's theory of moral development as well. It starts off in the early stages in a pre-conventional stage. That is what we see less than 5 years of age, where they want to just avoid punishment and they are happy to obey you to get away from the punishment, and then conforms to rules and regulations to get rewards and to have favors returned. So why do we look at all these? Why am I concentrating on some of these early childhood theories? See, especially Freud has actually said that there are significant future implications. Like if we are stuck in the oral phase of the Freudian developmental axis, there can be a lot of smoking, dependency, aggression later on. Mind you, none of this is 100% perfect, but it's good to have an oversight to understand that early childhood can have implications later on. Similarly, the anal phase and the phallic phases, actually issues there can have future personality fixations. Definitely, as I said, there are quite significant critics of child development theories. We really don't think that children are, passive. There's quite a bit of dynamicity going on. A lot of these theories look at deficit model theories, which actually is not 100% true. These are all normative standards for development. Fantastic when we look at normatives, but each child is unique. Each child comes from different family settings, different cultural settings, especially in Indian scenarios. So that uniqueness we lose out in this. And if you have looked at, psychosexual, psychosocial, cognitive, each theory concentrated on specific aspects, ignoring other crucial elements. And as we understand now, child development is continuous, evolving, overlapping, and there's a very much dynamic process. I'll just move on to some Indian perspectives. As much we look at what actually standardized theories are there, I just want to look at what Professor Sudhir Kakar, who recently passed away, what he talked about the Indian perspectives of early childhood. It's a fantastic book. If anybody has time, please go through it. It's available in most of the online, web pages to buy it. Indian individuality and sociality are different from Western traits. We are very much an interdependent society. Embodiment of one's cultural imagination is actually quite significant in one's conscious mind. Look at Vygotsky and look at Bronfenbrenner, it's just tying up a lot of loose ends. We are actually very much a communitarian person versus an autonomous person in most of the Western settings. And there is a significant role of spirituality or religion, as well as the early childhood rearing practices. And more recently, we have heard from Professor Vikram Patel, who is currently in Harvard. And what he suggests actually is most of the mental health problems are not very much individualistic. They're quite a significant social determinants, community resources, and what he has suggested, it's not him selling the first time. There is a significant life course approach where people are zooming out and seeing what is actually the life course approach, and that includes the early childhood and adolescent factors. And I hope, that the audience today understands that it is not just the workplace or the family, it is actually starting from early childhood itself. I've tried to summarize it, but due to lack of time, I will skip through. So what we have in Vellore, we have 2 birth cohorts that we have been following up the last 2 decades. We are doing the 3rd birth cohort now, extensive follow-up, including behavior and resilience that we have looked at. And we also have a neuroimaging facility, and we have looked at behavior and resilience in our cohorts to understand what early childhood factors, trigger some of these. I'll just skip this slide. When we looked at the development in the first 2 years of life in our cohort, we have around 250 children to start off with in a low middle income settings in urban Vellore, a birth cohort from the community. We can see the cognitive domain, the language domain, the motor domain, the social domain. Actually, the scores decline over time and significantly declining. And what actually drives these are mother's cognition scores, and nutrition factors, socioeconomic factors, anemia and iron levels, and also the home factors, how good the home environment is. It's affecting the cognitive, language, and motor domains. As many of us here are familiar, Professor Gardner had talked about the 9 types of intelligence, and I just want to concentrate on the emotional intelligence and resilience that Professor Rajesh has recently talked about. We're so very interested to understand what resilience is. Resilience, a modern definition, can be advancing despite adversity. Many of us has difficulties. How do we move on from difficulties? So we actually wanted to look at resilience in childhood. One of the resilience measures that we use have 3 domains: the individual domain, the caregiving domain, and the contextual domain, and the total resilience score. So we were keen to understand what drives these, especially from the early childhood factors. By my 9 years, we had only 200 odd children who we were able to follow up. And we can see that verbal cognition actually drives some of these. Cognitive ability definitely contribute to resilience. And nutrition factors, this is a bivariate analysis, maternal factors and home inventory, and definitely socioeconomic factors also contribute to resilience. So when we did a multivariate analysis to look at the individual domain as well as the total resilience domain, we could see that the cognition and the home inventory at home scores at 2 years actually guided that. home has two components, the physical component and the interactive component. So we really wanted to see what is it that driving the resilience, childhood resilience at 9 years. And we actually broke down the home environment, and we found out that the daily stimulation, how well the child is encouraged, given activities at home, actually have an effect later on. And the environment related domain also is important. The toys available, opportunities to play, interact, that also is important. So when we are looking at, we see that early childhood daily stimulation, the interactive home environment actually has a very significant factor in childhood resilience at 9 years is published. We also have looked at what guides the home environment because as Madam Kamini has said, home environment is very important. This is actually looking at the physical and the interactive environment. So what changes the physical environment? Definitely socioeconomic status of income, assets, maternal education, maternal depression, parity actually had a huge effect on that. While actually the interactive environment is purely guided by the maternal factors. So what do we have in the international evidence? We know that the early experiences and the brain development lay the foundation of sound mental health. Quite a few researchers and clinicians have put forth this life course approach. Disruptions in the early childhood, in this development process, affect capacities not just for learning, but relating to others. Most potential mental health problems will not become mental health problems if we respond to them early as early childhood, as early as maybe even adolescence for the mother. You know, there are a lot of questions out there, but we know that early intervention is the best. So, so this is actually a study that looked at early environment, how it influences the developing brain and the long-term mental health. And they did a linked independent component analysis and found out that socioeconomic factors, including parental education and income, had a higher, larger cortical surface area, higher gray-white contrast of brain, and childhood psychopathology was negatively correlated with the frontal and occipital surface area. And this study was done in 8.9 to 11.1 years in a large US cohort called ABCD study, around 10,000 children. Also, there has been other studies that have shown that the early negative life events can cause depression in early adulthood. The neuroimaging showing that there is a thicker orbitofrontal cortex, which not just in cognition, but also in behavior, emotion regulation is important. This actually is thicker at 14 years, maybe a coping mechanism, we don't know. And further on, it causes an accelerated thinning later. So we also have done looking at stunting and catch-up and brain volumetry, one of the first few studies in the world. We also shown may not be OFC and the overall cortical brain volume was lesser in stunted children. But we also have shown basal ganglia, subcortical structure, cerebellum, corpus callosum also have effects actually because of early childhood stunting, which continue to persist in childhood. Coming to what we talked about earlier, the nurturing care framework, WHO and ICMR and our national governments have all supported the first 1,000-day program, and the components are adequate nutrition, good health, opportunities for early learning, safety and security, and responsive caregiving. And there is actually early childhood education also, a similar framework has been suggested. And this is actually to look at the first 1,000 days to improve not just education, but mental health as well. So infant and early childhood mental health is the foundation for all future health. So there are a lot of contact points that we can work on. It's not just with pediatricians, but other mental health workers and childhood health workers as well. So in our country, there are significant resources are there. So we have the Poshan Abhiyan system, the CCD, the UNICEF WHO has got out, the MCP card system, the Palan 1000, I think it's a fantastic app. We recommend to some of our parents who come to us in early childhood, and the Poshan Ma that celebrates nutrition. And so there are significant resources are there, and really we're happy to work with these resources. But at times, I think this whether how much does it reach our parents? We wanted actually to do a study in our postnatal ward to do an integrated caregiver education module we had around 91 participants, all well newborns. The postnatal period may not be the perfect period. They are in pain, but we wanted to catch the population. So that's when we did. We introduce all relevant resources that is already existing, nothing, not finding anything new. We're not discovering anything new, all relevant resources, put it into a 40-minute session with handouts and e-links. Surprisingly, none of the parents had attended a parenting session prior. And our short training program, which is just a one-time, had shown a significant test score difference, showing that even a simple contact program can make a difference. Now, coming to the topic today, the workplace mental health and child well-being. This actually can be a very, very vicious cycle. How much do we support parents' well-being and support at the workplace? Around in Tamil Nadu has actually the maximum number of working women in this country. Around 46% of the total working women in this country belong to Tamil Nadu. How well are we supporting mothers at workplace? And definitely early childhood developmental workers, our ICDS and our, Anganwadi workers and VHNs, the fantastic workers on the ground. How well do we support them? And educator support systems. All these are people who directly interact with early childhood, in the early childhood with children. And how can we support this can be a discussion as well. And definitely there's mental health curriculum in the school for teachers and workers, but whether we can upskill them should be a question to raise. So I just want to talk about what can be a way forward. It's open for discussion. And I sometimes think it's important to look at life course health development. It is not just that person sitting in front of you as a patient. It's actually family is a patient. I think over time, we realize actually they teach us a lot. Family, the child sitting in front of you teaches you a lot as a clinician, and we should be humble to listen to them. How can we support healthy family environments, parent, child, and family relationships? How can we strengthen? How can we strengthen emotional and behavioral health of parents? So many of our parents actually struggle a lot. How can we support them? And how can we just fall back on a lot of our family and community routines? As I said already, supporting parents and childhood staff who are in touch with children in early life. And as ICMR is supporting a lot of studies, thank you so much for that. And let's look at the evidence and not just evidence, what can be the implementation studies to improve mental health and resilience in children. So in conclusions, first 1,000 days is foundation of life, not just for cognition, growth, life potential, but also for mental health. Childhood resilience is actually associated with early childhood stimulating home environment and maternal factors as shown in our study. Life course health approach should be included for all, mental health approach as well, and definite the esteemed professionals on the board also agree with that. And how well can we support parents and early childhood workers? Maybe each of us in our own place, we can have discussions will be a great way forward. Thank you. This is our clinical research and community teams, and I'm happy to take questions. Thank you.
Thank you, Dr. Beena. Thank you for a very enlightening talk. And as they say, childhood is the foundation for everything that grows later on. So that's why I think focus on having more a vibrant childhood and more complete childhood is very important. And for that, I think sensitization of parents is very, very important, because many a times I think mental health is something that we always take for granted. That we are always concerned when the child is not eating, we are always concerned when the child is not gaining height, but then we seldom really measure what is the mental health, how's the child faring on those indicators. And because those indicators are also not talked about much. And these days, I think parents are also kind of creating a lot of pressure at the level of the child, multiple classes and, taekwondo and music and art. And I remember when my son, he got a little confident of himself, he stopped going to all the classes. And after
Good for
that,
him.
he was very good at chess, but then he said, it is a lot of pressure in that 15 minutes, and I'm not going to play any competition for that. So, and I think we should respect that as well and not force kids. Thank you so much. And I think you really touched a very important topic of working mothers. I mean, I myself have been a working mother, and are we still connected?
Yeah, it's
Okay.
just
Yes,
now.
sir. I can hear you. Yeah.
So, I mean, and in my team, there are a lot of young mothers, who leave kids at home. So that's why it is very important that we create a more harmonious and a more supportive working place in our office. So, are there any questions? Can we look at the chat box quickly if there are any questions for Dr. Beena? Which objective measures would you suggest for assessing the effect of traumatic episodes on psychological well-being of 18 to 4-year-old children, 14-year-old children? Dr. Beena, that's the question for you.
Yeah, thank you for that question. There are many measures available, and some of them we need to buy them. If you're using a community study, I find the strength and difficulty questionnaire quite good. That gives you hyperactivity and attention component, the prosocial behavior, any abnormal behavior. And actually, it's a free measure as well. And there are measures the National Institute of Mental Health, Hyderabad also has developed. That also is not bad. But if you want to, use some measure that you're okay to buy, childhood behavior checklist also is a fairly good measure, which will give you internalizing and externalizing components of, behavioral issues. Thank you.
But I think we should be talking more about these indicators and these milestones, the way we talk about the nutrition, the other
Exactly.
cognitive milestones. Thank you, Dr. Beena. We will now move to, thank you. Yeah, to next speaker, and I request Dr. Ravleen to introduce Dr. Bhan.
So, thank you, ma'am. And we have Dr. Anant Bhan with us. He works with Sangath at its Bhopal Hub office and is principal investigator and site investigator for the various projects conducted at the hub. They are funded by both international and national funders. He is a medical graduate with masters in bioethics from University of Toronto in Canada. Dr. Bhan's academic training and work experience is in medicine, global health, bioethics, and health policy. Sir has, it's a huge long list, and sir will be speaking on no one size fits all approach to workplace mental health. We welcome you.
Thank you, Dr. Avleen. Good morning, everyone, and let me start by saying it's a privilege to be here at ICMR. Thank you to Dr. Walia, Dr. Avleen, Honorable Secretary, and all the other colleagues for the invite, and also to be on a panel with senior experts whose work I have been admiring and following quite a bit. So I think what I was asked to do is maybe expand on what the thematic focus for this year's World Mental Health Day is. And since Dr. Sagar spoke already quite a bit around the importance of workplace mental health, what I thought I would do is maybe do a little bit of a complementary focus on some other aspects which are relevant. And I thought I would also start off by acknowledging some work which has been highlighted. If you could go to the next slide, please, by ICMR itself, in acknowledging the background as to why we are discussing mental health, and that not just during COVID, but post-COVID, there's been a lot of interest in looking at mental health as an important facet within the larger health and development discussion. In fact,
Sir, the slides are not moving on the.
Sure.
Sir, if you put on presentation mode, that makes it easier, sir.
Dr. Sagar की presentation close कर दो.
नीचे से PPT वाली.
Presentation mode में नहीं है. First slides. Are you able to see it in the presentation mode?
Yes, ma'am.
Now it is okay? Okay, we can start, sorry.
Okay, great. All right. So if we could go to the next slide, I just wanted to begin by acknowledging the importance of mental health now in the discourse which is happening. In fact, even for post-COVID conditions, this is an important area of exploration. I'm part of the WHO post-COVID guideline development group, and one facet which is a strong area of focus is trying to understand the mental health impact in post-COVID conditions. Of course, all of you might be already aware that evidence clearly indicates that not just is mental health important, but the burden also is quite high, and most of it is untreated. So the treatment gap in mental health is somewhere in the range of 70 to 90%, which means likely 1 in 10 patients with a mental health condition, especially a common mental disorder, are likely not getting quality mental health care on time. And of course, that has implications on DALYs and years lived with disability. And this is well known. And of course, in parallel to that, we have a challenge, which is that we don't have adequately trained mental health specialists. So if you only rely on psychiatrists and psychologists, then they are largely concentrated in urban parts of the country. They might also be largely working in the private sector, which might be at a cost which is not affordable to many people. And also mental health services might not always be available. So that is certainly a challenge. If we look at, next slide, please. What the topic of this discussion is, again, the fact that almost 15% of working age adults have been estimated to have a mental health disorder. A lot of almost 12 billion working days being lost. Dr. Sagar spoke to this. And when you contrast that with how many people globally are working, that's around 60% of the population, you would already see that there is going to be a significant intersection of people who are working, who are likely also going to be having a mental health disorder, but is that again recognized as an important facet of workplace well-being is something to look at. Next slide, please. There are many risks which Dr. Sagar spoke about, so I'm not going to these in detail, but again, important to recognize some of them around unsafe working conditions, inflexible hours, underuse of skills, excessive workloads, violence, harassment, bullying, all of playing an important role. And of course, this work-life balance, which was also alluded to by multiple speakers earlier. Next slide, please. So I think with the incidents which happened in the recent past, both in Pune and Kolkata, Pune being in a corporate entity and Kolkata, the unfortunate loss of a resident doctor, where again, issues around long working hours came into public discussion. There is this larger interest also as to why is this the case, that there is this kind of a work environment and what kind of impact does that have on the mental health and well-being of employees, and also by extension on their physical health and general life. And that I think is important. I mean, in contrast, you would also see on the bottom side of the screen that sometimes people celebrate leaving toxic workplaces. So this was a person who resigned from his position because he had a toxic boss, and invited a whole Tasha band on the day he left because he just felt that he was being released from this kind of an agony that he was undergoing. Next slide, please. But important to also recognize, especially as many of you are researchers, scientists, clinicians, that more and more now there is a focus on also understanding what kind of workplaces do we have and how do factors like bullying and toxicity at the workplace influence career aspirations, career progressions, but also ability to function effectively and be able to utilize your talents in an effective manner. And this is something which I think more and more scientific institutions are also taking cognizance of. If you go to the next slide, you would realize that many funders, and because we are at the discussion ICMR, this might be an important point for ICMR to think about. Wellcome Trust, in fact, withdrew funding from a senior geneticist because she was accused of being toxic at the workplace, and a lot of her supervisees complained about it. And so a major grant was pulled away. And not just in that case, but also in another case in the same year, 2020, in 1918, there was another case where a famous paleontologist also lost funding, not because of concerns about the science, but about scientific conduct at the workplace. And hence this whole issue of responsible conduct of research now is also encompassing bullying, harassment at workplace as being areas where people are being looked down upon, and funding is being withdrawn. Next slide, please. So clearly, workplace toxicity is an issue, but it's not just a mental health issue, because as we mentioned earlier, it can also have implications on the kind of culture, on whether people want to join and work in those teams, on their physical health, and also the productivity of those teams, which is of course concern for most workplaces. Next slide. So Dr. Rajesh mentioned the fact that why it's important to also look at the informal workplaces, because a large majority of people who work are in the informal work area. So if you would look at people like vegetable vendors, those who work in the gig economy, so the Ola, Uber drivers, or the Swiggy, Zomato delivery agents who bring food to you when you're hungry on a weekend and you don't want to go out of your house, they're all part of this informal workplace. But of course, those workplaces also have a lot of stress, and that impacts their mental health and well-being as well. And hence the need to also look at this and do research in this area. So I think a lot of research typically happens in the more formal workspaces, within institutions, within medical workplaces, within corporates, but not so much in the informal workspace. And that is an area where more research needs to be done. And perhaps some of you who are researchers would want to look at this area. Next slide, please. And as I said, this is because the vast majority of people are largely working in the informal economy. Next slide. And in our own work at Sangath, we've been also trying to work with some organizations which are large collectives. So SEHA is a good example. The Self-Employed Women's Association is a large network of women, often in the informal workspace. And our idea is to work with them to try to identify the kind of mental health and well-being challenges which this large work group has. And some of the areas which have come forth already are challenges around climate change and its impact on, for example, women vegetable vendors in Ahmedabad, who are seeing now longer days, hotter days, sometimes untimely rains, etc. happening, and how it impacts them. And also many of these women also being now elderly or aging. And so what impact does that have? So I think trying to understand will hopefully help us come up with solutions which are more context specific. So that's an example of some work we are doing, and hopefully this is an area where we will see more work happening. Next slide, please. What's also important again is to highlight that community health workers are another group which are often not very formalized. So ASHA workers are a good example of that. At the Bhopal hub, we've been doing a lot of work with ASHA workers to try to bring psychosocial care to communities, especially depression care. And they've done actually a great job in terms of being able to address concerns around mental health and well-being, address stigma issues, initiate conversations. But it's also important to recognize that many of these workers, because they are also not formalized, themselves have mental health and well-being concerns, and these are related to the kind of workplace that they have. Next slide, please. So when we started working with ASHAs, especially during COVID, they recognized and told us that it's great that you're working with us to try to bring mental health to communities, but what about us? We are there for everyone. We are supposed to be working with communities, but who's there for us? And what can you do to help address this whole issue around work stress and coping among rural frontline workers such as ourselves? We published that data, and based on that exploration, then also wrote up a couple of projects which have then since focused on trying to bring solutions which would be specific to these communities. Next slide, please. A couple of these also involve, keep pressing the button, are innovative games. So, the snake and ladder game is something which everyone in communities plays with. So we've adapted that to mental health, and we call it Jeevan Ke Utar Chadhav. So challenges that you see in daily life, and with every move that you make, you might be able to look at enablers or stressors and be able to have conversations around that. And this is very useful to initiate conversations around mental health, because sometimes the language is not there. Sometimes there is a lot of stigma. So these might be mechanisms to initiate more community level conversations. Next slide, please. We've also worked on adapting the WHO Self-Help Plus program, which is something which health workers, including community workers, can do themselves, and try to adapt that for community health workers specifically. This is research which will be published soon. This was a pilot study. Next slide. And a large study, which is a randomized control trial, which is ongoing, where we've tried to look at positive psychology-based approaches using character strengths. This is a study called Anant, which is again trying to identify what could work for Ashas in supporting them and similar community health workers in being able to address their own mental health and well-being. So again, this kind of research hopefully will be useful. Now, I want to come to a segment which I think we've already referred to. Dr. Beena spoke about it, Dr. Sagar spoke about it, which is children, adolescents, and young people. And this is important because the mental health burden, especially in this age group, is fairly high. If you identify mental health disorders early, you might be able to intervene early, but most of the time that doesn't happen. And you would also see pretty high suicide rates in this population, among the highest in the world. But what's also important to remember is that this is a age group which, with changing work environments, so many of you will know of young people who, for example, are only produce social media content, right? They're influencers. So that is a workplace by itself as well. But with this focus on likes and attracting more likes or viewership, what does that mean in terms of social media and its impact on mental health? And that also has been highlighted as an unhealthy influence. And how do we address that and recognize that also as a workplace which needs attention, especially in terms of responding to the needs of our young people. Next slide. And this is also important because as people become more insular and spend more time on their devices, you are also at the same time seeing an epidemic of loneliness and isolation, which was identified as a major health issue by the Office of the US Surgeon General. Vijayakumar was actually just here last week visiting NIMHANS and discussing mental health and well-being issues as well. But as our lives become more and more isolated with nuclear families and again more focus on devices, what does that mean for our mental health and well-being when you intersect that with workplaces? Next slide, please. And this is something we've also recognized as being important in terms of trying to understand how this segment, adolescents and young people, what are the kind of challenges that they face. So with support from the Rajasthan Royals Foundation, which is the CSR arm of the IPL team, we work with young women sportspersons, adolescents and young women to try to understand what some of their mental health and well-being challenges were. And this sort of transcended anywhere from concerns around how to handle menstrual health when they were active sportspersons, how to deal with cultural factors where young women are not allowed to go out and play matches, especially outside their home, being able to negotiate a career in sports, which is not considered something which is acceptable, and the kind of, again, toxicity in their environment where certain people might be given preferences by coaches, etc. And we've seen that also play out at the national level in terms of coaches sometimes being abusers, etc. So again, how can we work with these kinds of segments to try to understand beyond the conventional work with corporates and institutions is important. Next slide, please. Young people, just a previous slide. With young people, we've also recognized that where they discuss mental health and well-being is also spaces that we need to access and be a part of. So in Bhopal, which is again an area where there is a lot of colleges, we've occasionally organized these kinds of open mics where people come in and do spoken poetry. They speak about their own struggles and it normalizes the conversation. So what is important is creating those safe spaces where young people can come forward and feel supported and where they can share their own struggles and then have other people relate to it. We've also done that with colleagues in Delhi and other cities where there are online spaces and websites like It's Okay to Talk, Baatcheet, where people are encouraged to provide peer support, etc. to each other. Next slide, please. Our work in Bhopal also has focused on working a lot with marginalized communities, so queer, trans community members, persons with disability. And one thing we have realized is that many times they don't go and access mental health care, one, because of the stigma, two, also because affirmative care is not available. So when you speak about to these communities, and many times our interactions with them might be limited, or you might see them at a signal and not want to interact with them. But are they really coming to our healthcare institutions? Are they able to access care? And hence, again, this importance of, in the kind of work that they do, how do we make care available for them? And we've been trying to develop guidelines and competencies around this. Next slide, please. And we've, again, recognized that part of what we need to do is to reform our own institutions, because we could be institutions working on health, on research, on mental health, but do we have policies which openly speak about the fact that our workplaces need to be inclusive? So within Sangath, we have come up with a policy which, taking account of the transgender Care Act and also the RPD Act, we now have an anti-discrimination policy and equal opportunity policy specifically for transgender and intersex persons. We're working on a disability inclusion policy, again, to make our institution inclusive and welcoming for individuals who are persons with disability. Next slide, please. We are also actually working on an employee mental health policy. So this might be something for ICMR to think about, that as an institution and as an organization, should we not have a policy which focuses on mental health and well-being, and that can cover many of the aspects of what we were talking about today, because in many ways the reform has to happen from within. We can keep talking in these seminars and webinars, but unless we bring about reform in our own institutions and workplaces, we will not be able to bring about that change perhaps effectively. Next slide, please. Lived experience, I think, is an important part, because as Dr. Sagar said, it is very important to talk about the stigma. But usually those who have the lived experience, people who are service users, caregivers, are talked down to. They are talked about in third person, that these are individuals for which we need to develop solutions or services, but are they part of the conversation? And this, I think, is now becoming important also because you're slowly starting to see a lot of celebrity sharing of struggles with mental health, right? So people like Deepika Padukone have spoken about it. There are others who've spoken about it. Unfortunately, we've had a few suicides, deaths by suicide by among celebrities, and that also, I think, has brought attention to this, the importance of lived experience. Next slide. And so you have anywhere from cricketers, in this case, R. Ashwin, talking about the fact that because of the stress of being in a very competitive game, how he was struggling with mental health issues, but not able to reach out and wanting to quit his workplace, which was cricket in that space. So many other individuals similarly, just as a way of example. Next slide, please. And this is also the issue around how is mental health portrayed is an important part of workplace mental health responses as well. The fact that often these, the reporting can be very alarmist in nature and inflammatory, and that's why people again go into a shell and not comfortable speaking about their mental health. So what can we do in our advocacy, in our mental health and media outreach to ensure sensitive portrayal becomes important? Next slide, please. And of course, we now also have this challenge where everyone claims to be a therapist, right? So there are influencers, dentists, homeopaths, everyone goes online and makes claims, says nice things about mental health, but whatever they are propagating, is that really evidence-based, is something that we need to think about. Because one thing is, it might not be helpful, but what is even more worrying is it could be actually risky and harmful because of the way the practices that they use might not be evidence-based, and they might actually end up harming especially young people or people who are vulnerable. So it's something to worry about. Next slide, please. So there are too many apps now, all offering mental health, not clear what evidence they use. There's a lot of fancy use of technology such as AI and ML, and that of course has a lot of advantages, but is that really based on science, and the way it is being approached is something we need to look at and do more research on. And of course, data privacy, ownership protections, because this is data coming from vulnerable populations that we need to think about. Next slide, please. So one thing I wanted to maybe very quickly touch on, I know I'm probably past time, is the gendered issue of this topic around workplace mental health, and the fact that there are a number of well-performing individuals, right? So if you look at the data, this is from Fortune, which looks at the corporate workplace, that almost 76% of high-performing women receive negative feedback compared to only 2% of high-performing men. And that probably is true of many of our workplaces in India. So as a woman who might be performing well, are you encouraged or are you discouraged? Are you looked down upon, and various questions asked of you, for example, that are you spending adequate time with your family? Are you providing for your children, etc., which might not be asked to a male colleague, and how that impacts their own perception of their work-life balance is important. Next slide, please. And specifically also for those of us who might be medical professionals, researchers, always this debate in our mind, are we, in our passion for work, are we also providing adequate time to our families, to our children? Are we able to balance childcare requirements with our career? And the toll that takes on mental health and well-being of professionals. And I guess for the same reason as the previous slide, this toll might be certainly much, much higher among women colleagues. And what does that mean, and how workplaces can be sensitive to that? Dr. Wali, you were mentioning you have a lot of young women colleagues in your own team. I'm sure this is an issue which comes up as a supervisor, how do you sensitively respond to those kind of requirements? Next slide, please. So of course, as Dr. Sagar said, we also need to recognize that within the medical profession, our suicide rates, our mental health morbidity is much higher than the general population, and that is also linked to the kind of workplace stress that many of us go through in our training, in our practice. And are we again recognizing that? How many of us are comfortable speaking openly about our own mental health struggles is something to think about. Next slide, please. And hence again, what does that mean in terms of health worker burnout? And what kind of changes do we need to do structurally to be able to take care of our health workers? Because if our health workers and their well-being is in peril, then we will always struggle, whether that be in ordinary work situations or crisis situations like COVID. And we saw how sometimes our health system struggled during COVID, with also health workers being extremely stressed out and burnt out, and that can be a major challenge for health systems. Next slide, please. So part of what we've tried to do more recently is also do public engagement around some of these discussions and take the discussion beyond the conventional discussion we might have in webinars with professional colleagues, but to take it to communities. And this is a series of conversations we've had at the India Science Festival, talking about neurodivergence, talking about bipolar conditions, etc. More recently, next slide, we just did a large meeting in Bhopal at the National Museum of Mankind, where a cross-section of Bhopal's community came in, and we discussed mental health in the workplace and tried to discuss this as an important issue. And maybe some of you can also try doing that by taking these communities into the open and in public engagement. Next slide, please. And again, just to remind you that as a government, also we have committed to addressing mental health challenges. Just last year, there was a declaration, a CRO declaration, where our then health minister also signed on to this declaration and saying that this is something that we will focus on from a policy perspective. Next slide. And speaking about moving away from a biomedical disease-centric approach to a more well-being approach with community engagement, with moving to a biopsychosocial approach. Next slide, please. So by having these open conversations, can we try to address stigma and discrimination? My argument would be yes, that by having more public engagement and discussions like this, it would be useful. And next slide. And that would mean that we are then moving towards an enabling environment with leadership, investment, a focus on rights of individuals with mental health issues, integration of mental health into workplace and well-being efforts, participation of those with lived experience in decision-making, focusing on what works in terms of evidence, and ensuring that we are complying with applicable policies in this regard. Thank you. I hope that was useful in terms of the conversation.
Yes, thank you so much, sir, for your very extensive talk, and you have touched not just the organized sector, the unorganized sector as well, and you've spoken about the solutions that we can end the stigma by opening up and talking freely about it. But are we really listening is the question. I mean, responding is something very different, but are we really listening? I saw your panel discussion also yesterday, the one you shared with me, and in that also this topic came up. So do you have any thoughts on that?
Yeah, so I think part of the challenge is certainly a reluctance to engage and to recognize, and we see that in all the sectors that we deal with, whether that be working with the formal health system, whether that be the NGO sector, which I do a lot of work, whether that be the informal workspace, and people perhaps don't recognize mental health and well-being as being as important, if not more important, than physical well-being, right? So people are comfortable talking about their diabetes, hypertension, they will talk about the fact that I take medication for non-communicable disease, but struggle to sometimes even have the language around talking about some of their own struggles. And if we can create more spaces where it's okay to talk about your mental health, it's okay to take a leave and say, the reason I want to take a leave is I want a mental health rest day, right? And for your supervisor to not say, what the hell is that? And why would you even want to consider that? When we will reach a stage like that, where people feel comfortable and understand that we could be stressed out, for personal reasons, for family reasons, for work reasons, and we might just need a break for that. I think that change can happen. And that's where I think in our own organization, in small ways, we've been trying to think about some reform by opening up, because sometimes we pretend to be working on areas, but we don't sometimes even in our own circles talk about what needs to happen differently. And hopefully that is part of what we need to do.
So thank you. Very interesting discussion, and you touched very important topics: the gender, the problems with the healthcare workers who are out there working with the community, and many a times working in very resource constrained environment as well. We all know they are not adequately compensated. Still, they are out there in the field working for us. And also, you talked about the safe spaces. So that's what I was asking Dr. Sagar also in the morning, that we don't perceive the treatment spaces as safe spaces. And we have to look at more on a prevention approach. I think the West has done very well on this. Even many people, they talk of going to a counselor regularly and talking out their problems. And that is something kind of support we need. And I think you also highlighted the importance of having trained counselors and trained psychologists who can support, because there is such wide variety of I come across many adolescents who need these kind of counseling, but the parents don't know where they should find a counselor. So that is one area I think that really needs consideration, something like accredited counselors, or because these days even someone who has done very basic psychology is also becoming a counselor. They may have very good skills, I'm not denying that, but I think we need to create certain benchmarks that if a lot of people are going to need that support, who is providing that support and what kind of qualifications and skill sets those people have. And I think all these issues are very, very important. And when Ravleen proposed this topic, I never realized I would be so interested in listening to all talks myself. So thank you, Dr. Bhan. This was a very, very interesting discussion. And do we have any questions for Dr. Bhan on in the chat?
One is measure to combat burnout at office, I think, and next is I feel pathetic type of admission. No, ma'am, that's the only question there.
Measures to burnout, measure the indicators to measure the burnout in the official.
Yeah, in official workspaces. So I think the query is again about how do we, well, first thing I think, as you were mentioning, Dr. Walia, is the approach should be a prevention-based approach. So how can we anticipate the fact that there are going to be situations where there could be a lot of stress? You know, for example, you have a funder report you, right? ICMR needs your report, you know that you have a project, and ICMR program staff is going to be after your life to get that report, because they of course need to also close their files. Then if you can work backward from it and ensure that your team is not waiting till the last moment to submit it, that's an example of how do you prevent a stressful situation and burnout. We also see sometimes, as you were rightly saying, that we work in a very resource constrained environment. So even anticipating that if I'm going to submit a research project to a funding body, how many people do I really need to work with? If I'm going to hire 2 research staff and then expect them to do the work of 5 people or 6 people, and then stress them out and one, not pay them adequately, but also expect so much of them, then it's a pathway to lose them very quickly, because at some point in time they will burn out. So it's being fair to recognize what kind of work is required, how many people are required, and also what is a reasonable time, and then maybe have conversations with your funders. And I think our funders are also more receptive to some of those conversations if you can make the case. But the case has to be made, otherwise we will be reaching a burnout stage. So anticipating as a manager, knowing how to manage your teams, as an employee, knowing when you feel that you are getting to a situation where you are not able to cope up, and we saw the symptoms of burnout which Dr. Sagar shared. If you know that you're starting to see any of that, please have conversations in your workplace, reach out to your manager, access mental health care, take a break if you need to. And that hopefully will ensure that you are able to cope. Otherwise, we see a lot of loss of employees because of this. It's very common also in high pressure situations like residencies, where a lot of young talented medical graduates also just leave certain disciplines because they are not able to take it and they don't feel supported, and it reaches a stage where they're not able to cope.
So I think stress if we summarize all we have heard and just focus on the stress, mental health in the workplace, I think the stress in the workplace is influenced by the individual's own, mental makeup, and also how he perceives himself, and also the environment contributing, the workplace actually contributing to that. So I think both have to work. If we really want to address it, the individual has to work at his own level. Many a times, there is also this thing that people see their self-worth through other people's eyes. And that is very common. And those people are the ones who actually are more vulnerable to it, I think. So that it is I think, a lifetime of work, and more of it, as Dr. Beena pointed out, in the initial years when you are an adolescent and when you are developing mentally and physically, and how you perceive yourself. There was an important question there, that how to motivate your co-worker or a colleague to go to a counselor if they are having issues when they don't want to go.
Yeah, so that's a good question. I think, one has to recognize that peer support sometimes works better. People sometimes are not very comfortable going to a but it is possible to also offer some level of first aid. And there are mechanisms where psychological first aid can be offered, where you speak to individuals, provide them inputs which could be helpful, and then slowly encourage them to access care. And sometimes that's more well received when it comes from a peer, a friend, or someone from your own circle. And so people can at least learn the science of doing psychological first aid. You could have these kinds of individuals available within workplaces who are not offering specialist care, but are just offering psychological first aid and support, and then encouraging people to feel comfortable accessing specialist care if required. So I think that is certainly possible to do in your own workspace. And if you see someone struggling, I think it's always a good idea to reach out, have open conversations with them. Because of the stigma, many people are not comfortable speaking. But if you are just there and you offer a listening ear and a supportive space for them to perhaps open up, then that would be the first step. In fact, it could also help save lives in some cases.
Thank you. Ravleen, we can now invite the next speaker.
Can we just?
Oh, yeah, sure. I will forget. It was all your hard work, I think. Thank you. Thank you, Dr. Bhan, for a very interesting talk.
So, thank you, sir. Moving on to the next session, Dr. Lakshmi Vijayakumar, consultant psychiatrist based in Chennai, India, is the founder of SNEHA, a pioneering suicide prevention organization in India, and head of Department of Psychiatry in the Voluntary Health Services, a multi-speciality hospital in Chennai. She is an honorary associate professor in the University of Melbourne, Australia. She is also on the World Health Organization's International Network for Suicide Research and Prevention. Ma'am, I invite you to speak on suicide prevention in the workplace. Thank you for joining us from Chennai, ma'am. Although we know there is an orange alert and...
No, but it is sunny today. I spoke to someone in Chennai.
Oh, good then. Good, ma'am.
Thank you very much. Thank you very much. Really appreciate, and thank you to everybody in the ICMR for giving me this opportunity. And I think there is an advantage of speaking last, because then whatever many people have said, so I was actually deleting a lot of slides, so it will be very short. So without much ado, I'll just go to the first slide. So this is the suicide map of India. And you can see that we lose about 170,000 people to suicide every year in India. And 50–60% of them are below the age of 35. So we lose a lot of young people. And so it is not only a loss to the family, but to the country, the economy, and everything. And this pattern of suicide is been persistent for the last 20 years, where the southern states have high rates, the middle states have middle rates, and the northernmost states have the lowest rates of suicide within India. So there is a huge variation in suicide rates within India itself, with Bihar having the lowest suicide rate amongst all the states. And this pattern has been persisting for the last 20 years. But the magnitude of the problem is just not 1,70,000, which is according to the National Crime Records Bureau. Even if we say there is a 20% underreporting, and for every suicide, we say there are at least 20 people who attempt suicide, and every suicide or a suicide attempt affects at least 6 people around them, family, friends, workers, colleagues. So if we do the calculation, 1 in 57 of us will be involved in a suicide or an attempted suicide of a person every year, which means I see that there are about 250 participants in this symposium, and then at least 5 of us would have a direct impact of a suicide or attempted suicide this year. So that is the magnitude of the problem. Now, if you look at what are the kind of professions, because this seminar is about workplace, I just wanted to look at what are the professions where maximum suicides happen. And actually, if you really look at it, the daily wage earner has the maximum number of suicides. Okay, 26% of suicides happen amongst the daily wage, and their workplace scenario is completely. There are 3 factors which define their scenario. One is total lack of control over their work, total lack of income, and at the mercy of a person who employs you for that day. So this really is a major problem. And the next, of course, is the housewife. The housewife who works, the house is her workplace, but she's never recognized, she's never appreciated, and she's never monetized even. And okay, so those have the high rates. And then if you look at salaried persons, we have actually salaried persons have higher suicide rate than people who are unemployed, which is a little surprising, that there are 9.6% of people who are employed, but they still end their lives by suicide. So if you look, disaggregate the professional sector, then you'll find that majority of the people who died by suicide are salaried people, are in the private sector enterprises. And actually the lowest percentage of suicides are from central government servants. They have the lowest suicide rates, are followed by, but the highest is in the private sector. So which goes to show that we need to focus on a lot of regulation of people who are working in the private sector, which means we need to have a multi-stakeholder meeting with the management, with the labor unions, with the workers, if we have to make a difference there. So there is suicide, there is no single reason. I just wanted to share one thing about this, one slide about suicide, because I don't want to go into a lecture about suicide. But a lot of things have to go wrong for suicide to happen. There is no single, we don't have a staphylococcus or streptococcus, we don't have a suicidococcus which causes suicide, okay? There is multiple reasons, and this is a slide which we put together, I put together with the colleagues from Harvard, to have one single slide which shows all the risk factors which are associated with suicide. And I won't go into the detail, but I'm sure you know that it is important to know that it is multi-causal. There is no single cause. And then if you really look at the suicide at the workplace, these are all the reasons which has been found among people who have died by suicide at the workplace, okay? And I won't go much into this because both Dr. Rajesh Sagar and Dr. Anant Bhan has spoken extensively about what the situation is, okay? But the fact is, most of the workplaces do not have what shall I say, a system in place to address mental health issues, okay? They have systems, at least Some of them have systems in place to address physical health, but they do not have they do not have a system in place for either finding whether there is a mental health place or whether there is any place for them to de-stress and things like that. Most of them don't have this, and even many organizations don't even have an employee assistance program. And if you look at the HRs, particularly in the software industries, their job seems to be hiring and having exit interviews. They are not really looking at the issues. So the most important factors which have been identified with suicide is job insecurity. You don't know whether you're going to have a job next week. That is a major factor. And lack of autonomy. You don't have the autonomy. You're simply a robot. You can't use your skills. You can't use your mind. And lack of variety. Okay. And of course, I don't want to go because people have already talked about the work-life balance, family-work balance, and everything. Okay. And many of them feel trapped. Those who have died by suicide felt that they are trapped. They have no choice but to work in this situation because of other constraints, and they don't really like the work. That is what was found out. No, of course, suicide leaves everyone shocked. Okay, the loss is sudden, unexpected, it is and the reaction is hurt and anger also. How can that person die? I mean, they are leaving the family, they are leaving me feeling bad. And, and you're always riddled with what if I had done this, or what if I had spoken this, and this, when a suicide person dies, it leaves the other people with a kind of a life sentence. So that's the effect of suicide. And a lot of people think that we cannot identify who is a person who is suicidal, but 90% of the people, 70 to 80% of people who die by suicide have communicated their suicidal thoughts by actions or feelings, or even definitely to other people, but the other people don't listen to it. And many people have two ideas. Either they feel that suicide is something which an individual does, so we can't do anything, or we think it is due to poverty, unemployment, over which we have no control. But neither is true. For majority of the people, suicide need not be the solution. Most of the people, if you talk, 80% of the people who die by suicide are not sure they want to die. The wish to live and the wish to die is like a seesaw battle for them. So at that moment, they wish to die. Okay. If you talk to them, most of them would say, it's not that I really want to die, but I cannot go on living like this. So that is what they say. And we have a lot of empirical evidence-based interventions to prevent suicide, which is both selective, universal, and indicated. I again won't go too much into detail about this because that will take a long time. But to come back to what can be done to prevent suicides in a workplace, this is the framework which is considered the first framework. This was developed by the Air Force of the United States of America. They found a lot of their Air Force people were dying by suicide. So they went into a detailed mechanism and they brought out a blueprint on how they can reduce suicides among the Air Force personnel. And this was what was discussed. And one of the most important thing was to remove the stigma, seek for help and advocacy, and then social network promotion. These were the key factors. And of course, leadership training was very, very important. So if we have to just cut it down to size, how we can prevent suicides in the workplace, we can do it in upstream, midstream, and downstream. Upstream is shift the workplace cultural perspective. Okay. So many people, how we approach for example, in SNEHA, we conduct a lot of suicide prevention awareness and training for many of the software companies which are here, not only software companies, even for the Air Force police stations and everybody. And the one thing which we focus on to change the cultural perspective from top down. It is not enough to do with the worker, but to do with the managers also. And most of them understand that looking at the bottom line is not cost effective, because the amount of training they impart on a person, if they are not being productive, they actually lose more. So that is the slide which we put in, so that they know that if they spend time on mental health and promoting mental health, they actually, company saves a lot of money. No, that is an important factor which we should tell them. So cultural perspective, because in this competitive world, we find that cooperation is not there. So how to build cooperation and network, develop life skills and improvement, definitely knowledge about mental health, addiction and knowledge. So many of the people working in work environment, when the job stress becomes heavy, they get into using addiction, any form of addiction. Okay. And we find what is worrying is that many women have started being addicted to alcohol recently, particularly the younger generation. The minimum age of alcohol has dropped down from 18 to 14, the first drink, and the number of users have increased tremendously amongst the women population, which has dire significances for in terms of their productivity, not only that, as a woman, worth, everything. And then at midstream, we have to, there has to be a system in place to identify people who are stressed. We have to improve help-seeking behavior and increase access to quality care. And downstream, once you have an employer whom you recognize as having a mental health issue, provide appropriate mental health services, support, restrict access to potentially lethal means. Simple strategies. For example, we had a series of people jumping from high-rises buildings in the software industry here. So we just told them any high-rise buildings, the top floor is locked, okay, until it is unless it is it's a function where, and you have to have so many guards for that. So that has reduced the number of people jumping from the high rises in the software sector in the OMR road in Chennai. Okay. And most importantly, many of the companies call us because after a suicide happens in their workplace, they don't know how to deal with it. So that is the time when we go there to provide support to those people who have lost a colleague to suicide, so that we can prevent cluster suicides, because we know that cluster suicides are a phenomenon and many clusters happen. So we have developed a program called cluster prevention. So if any organization calls us, or even schools, saying that we have had a suicide, we go and do the cluster prevention so that there are no copycat suicide and there are no clusters. Now, I want to talk about, maybe before this, I would like to talk about some of the work which we have done. I didn't want to show slides on that, but we have done a lot of work on reducing suicides amongst the farmers. There were 2 studies which we have done. I didn't put it up, but in those papers which has published. One is we found that 60% of pesticide suicide and farmer suicide happens in the 4 semi-arid regions of Telangana, Andhra Pradesh, Karnataka, and Maharashtra. So we did a preliminary scoping study, and then along with a Center for Sustainable Development, we identified 4 villages and promoted non-pesticide management of pesticide. That is, they will use ginger garlic paste, cow dung urine, female pheromones and all that, but they will not use pesticides. So at the end of 4 years, the non-pesticide villages had not only reduced suicide, we identified these villages because there were a lot of farmer suicides there. So we used the widows of the farmers to be the champions in this project. These non-pesticide villages not only reduced suicide, but they got out of the debt trap because they didn't have to buy seeds, they didn't have to buy fertilizers. Their product sold better because it was organic. And so much so, they formed a cooperative movement and formed a neem seed crushing machine themselves. So that made us understand that we have to somehow reduce pesticide suicides, which is a very big problem amongst the farmers and young people in the rural area. So with support from WHO, we identified 4 floriculture villages in Tamil Nadu and set up what is known as central storage of pesticide. Like a bank locker, we built a locker for all the farming households to store their pesticides. And in the last 10 years, we have found that those villages who had a central storage has almost 0 pesticide suicide compared to the neighboring villages. This has been rated by the WHO as one of the most effective, cost-effective thing. And now we have replicated in the Mehsana district in Gujarat, where we have put in 54 villages, central storage where farmers store their pesticides. It's a simple strategy. Apart from that, we have, as I said, we have worked with the Air Force, we have worked with the refugees. We have basically we have worked with a lot on community interventions using lay volunteers to provide support. Now, coming back, I thought I'll focus a little bit on medical students, which we are starting to work now. And this is the report, which is a sad state that there are 64 MBBS students and 58 PGs who died by suicide in 4 years. And more worrying is that people who have gotten into MBBS and post-graduations, about 1,270 have dropped out of that. Okay, so this is a worrying factors. And if we looked at what are the area specialities, these are the anesthesiology scored, they had the highest number of suicides, actually followed by psychiatrists as OG and psychiatrists. And the reasons cited are academic stress, marital discord, 25% had mental health issues. 25% of our mental health graduates have mental health issues. And harassment is 20%. So what was the academic stress they had? Long hours. And most of the survey which we have done found that most of them don't eat nutritious meal. They advise nutritious meals to mothers and children and everybody, but they don't eat. Most of them use fast food, sleep deprivation, inadequate rest, and a high level of personal expectations and family expectation. They have worked hard. They have gotten into this into prestigious medical course, and somehow their expectation is that they cannot afford to fail. Okay, and another important factor which many postgraduates are saying is, as a postgraduate, we are supposed to do an MD thesis and do a research project, but we don't have a dedicated time for that. We don't have a dedicated support for that. We, as postgraduates, we actually run the department, we work maximum, and we are so tired, and we don't have a allocated time for us to do the research. So we just do something which is not comfortable even for us. So of course, there is at the early stages ragging, and this discrimination also we found. For example, we did find, even I was asked as a part of a task force to study suicides on IIT by the union government. And we found discrimination based on caste is still a significant factor in many higher educational institutions. And language barrier is also a major factor. Of course, we talked about high expectations, financial troubles, disturbed families, and so on. So who are the vulnerable students? Those who lack social skills, who don't have a support, who have language and communication problem, have financial academic difficulties, and family problems, and people going to minority groups. So prevalence of depression in medical students is a meta-analysis. I don't want to because Dr. Sagar has already mentioned it. Okay. So why does suicide happens in medical students? Because they are the last persons to seek help if they're for an emotional problem. And they are very reluctant to take any psychotropic medication because they read up all the adverse drug reactions and they don't take. Even if you're depressed or something and you give them a small antidepressants, they don't take. Okay. They have a huge apprehension about taking the medication. If we advise them to go for psychological therapies like cognitive behavior therapy or anything, the time constraints makes them drop out. And the most important thing is they have huge stigma. If somebody is taking thing, the professors are do make fun of them in front of everybody. Or if it comes to be known that he is taking antidepressants or a mild antipsychotic or anything like that, then they are not given responsibilities commensurate with their qualifications. They are not given due recognition. And that really upsets many people, and they don't seek help. So they don't seek help from other people. Recently, I had a student who was doing post-graduation, who knew she had depression. So she went and told her professor, I'm feeling depressed. I think I need to go. And all the professor said, nothing doing. You're fine. You're intelligent. You're fine. You can come out of it. Just focus on your work. You know, that was a remark given. And 2 days later, she hung herself. So we need to have an increased awareness, not only among medical students, but at all levels if we have to reduce this huge loss to the country. And they have knowledge of lethal methods. They have easy access to means, and they see life and death every day. So there is a fearlessness, which is an important factor to suicide. No, you should not be fearless. You should be fearless about the method and about death, which is there in other common people. And what is surprising is that everywhere, even in the US, female physicians die more by suicide. And that too, it's not in the early years of life when they are struggling or when they are dealing, but when they are in 40s. So we don't know why female physicians at 40 have a higher suicide rate than other females in that age group or other male doctors in that age group. So that is something which we need to be done. Finally, I know I am running out of time and you are being patient. We do have a national strategy. After almost many years of working for it, we do have a national strategy, which is there in the health in the government website. But unfortunately, it was done. It was put in the website in 2019 November, 2021 November. But we have not yet implemented it. And it's time we implemented it, because the aim is to reduce suicide mortality by 10% in India by 2030. And if we have to achieve that, then we have to implement the thing. The other thing which I wanted to say before I close is what both the esteemed speakers were saying, that we need to go to the place of people and we need to see how community interventions and health services interventions are seamlessly intertwined, so that the community identifies people who are at higher risk of suicide, seamlessly transfers them to the health system, and once treated or something, the health system seamlessly transfers these patients for community support. Finally, I would just like to say this is called the Schneidman's Q. And he said the person who has the highest suicide risk is a person who is at the extreme end of psychological pain, extreme end of environmental stress, and extreme perturbation. This is the person who is at a highest risk of suicide. Somebody who is in extreme psychological pain, extreme environmental stress, and extremely mentally agitated. So even if we cannot do anything about the environment, if you are able to reduce the psychological pain and anxiety and agitation by one cubule to here, then the immediate risk of suicide is reduced. So suicide prevention is possible and it is everyone's responsibility. Thank you.
So, thank you so much, ma'am, for such lucid, I think it was an extremely nice talk on such I think it's a difficult topic to speak on, and just to listen to you was very nice. Are there any questions in the chat box?
Yeah, I see one question. How feasible it is to implement suicidal screenings in workplace? It is feasible because we have something called ask you questions and all that. Just 4 questions. But what is important is that once a person screens positive, the person is not stigmatized. The person is not, the person is provided help, supported, and not victimized. The many previous screening questions become negative because people are worried about doing this. So one way of addressing this is that we ask an outside person to screen and take over, so that nobody in the organization knows, nobody talks to them like that, nobody impinges on them. So the organization employs an outside person to screen, and a limited number of people know and provide support.
Ma'am, can you share your experience? Ma'am, can I ask one question, ma'am?
Yes, sure.
Can you share your experience, like out not only in workplace and like any friend circle or network system, how to identify, like, can you share some tips to identify suicidal thoughts and to prevent them?
Yeah, as I said,
Gatekeeper training kind of few tips you can, if you share, it is more benefit to all audience.
yes. So definitely, as I said, majority of the people, 80% of them do tell other people that they are suicidal. In fact, I had a slide here. Can I go back to that?
Yes, ma'am, please do.
1 minute. So you have behavioral symptoms. You have these are all the warning signs. Okay, you have anybody who's feeling desperate, worthless, angry, lonely, guilty, sad, worth, helpless. Most of them say it. Okay, the actions they do is, this is behaviors. They give away possessions, they withdraw, they abuse substances, alcohol, they become reckless, and this differs from age to age group. For example, a young teenager will not show classical depressive symptoms, but will throw temper tantrums, will become irritable, will present as conduct disorder. Whereas an elderly woman who may present with crying and guilt and things like that. So it differs from age group. Okay. So extreme mood swings, increased impulsivity, and self-injury. These are all the actions. Then the physical appearance is, somebody who's withdrawn, who doesn't look like how they used to be. They have changes in appetite, weight, change in sleep patterns. These are all the physical symptoms. And then you have thoughts. All my if they make remarks like, all my problems will end soon. I can't take it anymore. I wish I were dead. You will be better off without me. I can't do anything right. The only way you will understand me is when I die. These are all symptoms which they say. And most of the time, we are very reluctant to ask whether he is or she is feeling suicidal. We somehow have a feeling that if we ask them, we will introduce a thought into them. In fact, asking whether a person is suicidal or not is the first step towards prevention. It is the first step towards understanding what the person is going through, so that we can activate, support, and do what needs to prevent that particular thing. So the most of the time we don't ask, we assume. So instead of assumptions, if we ask a person, are you feeling suicidal? And if the person says, then you have a conversation.
Thank you, ma'am.
Are there any other questions? Just check once. Lack of empathy and insensitivity in the current hierarchical setup is worsening the situation. This is very true in the corporate.
What is that?
Ma'am, I don't see any further questions. Sir, you have any remarks?
No, I just thank you, Dr. Lakshmi. I think that was great, very useful, and a lot of practical tips also. You were mentioning the work around pesticides and how in Tamil Nadu that has been a lead, and some of that work now in Gujarat also. I know with CMHLP you'll be doing. So, are there thoughts around what is the kind of policy actions and also research areas? What can researchers in the audience, maybe where are the gaps from a research perspective on understanding suicide prevention?
In terms of policy, I think we do have a policy. As I said, the national policy is a good policy. I think there are many stakeholders who are involved, but it doesn't bear fruit if you don't implement it. So suicide requires multi-stakeholder. It's not enough. It's not only a health matter. You have to involve the education sector, women's welfare sector, agriculture sector. So there have been some talk about banning some class 1 pesticides, which is good for not only for preventing suicides, but also protecting the environment. And so there has been some talk. We have banned some, but more needs to be done if we have to comply with the WHO guidelines. And in terms of research gaps, I think the major research gap we have is we still do not know why there is such a huge variation between the North and the South. So that we need to identify and see what needs, why the South has so much, and see what can be done about it. But the emerging, what shall I say, the danger is social media and internet addiction and suicide. Particularly for the young people, we now know that every more than 2 hours, every 1 hour increase in social media increases depression, suicidal behavior by 9% in adolescent girls. So we have really unleashed social media on an evolving adolescent brain. And unless we work on it, we are going to have more and more. Already we are seeing so many people with self-injury and suicidal behavior. We know that 1/3 of the students are cyberbullied and 1/3 of them are suicidal, which is a huge number. So if we have to reduce suicide, I think we have to address this issue immediately. But we have had some policy changes which have been extremely good. For example, the introduction of, thanks to SNEHA's effort, the introduction, Tamil Nadu government was the first to introduce the supplemental exams for both 10 and 12, which has reduced suicide, exam failure suicides in Tamil Nadu by more than 60%. So now other states have followed that. So if anybody is interested, I've written about it in Lancet regional issue just recently, I can say that. And another policy initiative which we have taken in Tamil Nadu is called Manam. The health department has taken it, where all medical colleges will have a mental health exposure and support system, where peer support system, where people can go to for help, which is rolled out in a few medical colleges, but it's going to be rolled out in all the medical colleges.
No, I think, Dr. Lakshmi, do you think how much of the North-South variation is also a factor of data reporting quality?
No, yeah, very true. We thought it was the question of data reporting and not anything else. But if you really look at the million death study with which Vikram and I published, that also shows similar pattern. Okay, the percentage of underreporting is more in the northern states, but the pattern remains the same. Whether it is the WHO Global Health Survey or the GBD Global Burden of Diseases study, the pattern is the same. That is the problem.
Yeah, and I think the Sri Lanka also has fairly high rates, no? I mean, if
Yeah,
you look at neighboring countries also, that might also be another way of trying to figure out
yeah.
within South Asia. Thank you.
So I think we've come to an end of this awareness workshop, and it is indeed my privilege to propose a vote of thanks. First and foremost, I would like to extend my deepest gratitude to our esteemed speakers. Your expertise, perspective, and contributions have truly enriched our discussion today. I would like to thank Dr. Rajeev Behel, Secretary to Government of India, Department of Health Research, and Director General, Indian Council of Medical Research, for sharing his knowledge with us today. I would like to thank Dr. Kamini Walia, Head of Division of Descriptive Research, for her support and guidance to organize this workshop. I would really like to thank all the speakers for sharing their expertise with us. Dr. Rajesh Sagar, sir, Dr. Beena Koshy, Dr. Anant Bhan, who's taken all the effort to come here just for this talk. Dr. Lakshmi, Vijayakumar ma'am, who has joined from Chennai despite all the challenges she's facing. Thank you so much, ma'am. Thank you, sir. I would like to thank all the participants for your active engagement throughout the meeting. Special thank goes out to support staff, IT staff, staff at ICMR, whose hard work behind the scenes have made this meeting possible. I would finally like to thank everyone for their presence here today. Thank you so much.
Thank you. Thank you for the opportunity. And I'm really sorry I was not able to come. I would have loved to meet Anant, but
You had your commitments. Thank you so much.
thank you. Bye-bye.
Bye, ma'am. Thank you. Thank you, sir.
Thank you. Thank you. Yeah.
Hey, Rajesh.
Thank you.